Welcome, doctors. Good afternoon and welcome to this webinar on influenza and its prevention. On behalf of Hetero Healthcare, I extend you a very warm welcome. Hetero Healthcare, as you know, has got 30 years of excellence with 300 plus products in portfolio, 20,000 plus employees globally, and we have got Asia's largest API manufacturing at ACZ complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customer across India with a wide product range encompassing multiple specialties like in orthopedics, pediatrics, dermatology, gynecology, etc. We pioneer in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are rituximab, darbepoetin alpha, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero it's introduced oseltamivir, favipiravir, and remdesivir. And for all this, Hetero has received an award of Pharma Excellence in August 2020 for COVID drugs. With a brief introduction of Hetero, I hand over the session to Dr. Sainath Pawar and Dr. Swati. But before that, let me introduce both these doctors. Dr. Swati Shrotri is a consulting pediatrician and neonatologist since 1996 at Dattakashi Hospital, Satara. Madam was passed with distinction fellowship and diploma in child adolescent disease, passed diploma in child nutrition from Boston University, USA, director and founder Chirayu Children's Hospital, Satara, life member IMA and Indian Association of Pediatrician, National Neonatologist Forum, Infectious Disease Pediatrics, and served and arranged free camps around Satara, participated in free camps at Lok Biradari Prakalpa, Hemal Kasa, Dr. Amtesh Prakalpa, and at Surge, Dr. Abhay Banks Prakalpa at Gadchiroli district of Maharashtra. Dr. Sainath Pawar is MBBS, MD, DCH, FCPS, Sir is Fellow in Allergy and Asthma from University Hospitals of Leicester, UK, Certified Pediatric Flexible Bronchoscopist by AAPAS, APPS, and IAP, Consulting Pediatrician and Pediatric Pulmonologist. Dr. Sainath is Consulting Allergy and Asthma Specialist and is President Kolhapur Association of Pediatrics 2024, National Trainer for NTEP IAP Action Plan, National Trainer for Pulmostar IAP Module, National Trainer for IAP REAP Module, Executive Board Member for Maharashtra Respiratory Chapter of IAP. A warm welcome to you, Dr. Swati and Dr. Sainath, and over the session to you. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you. One second. Yeah. So, thank you, sir, for kind introduction, and thank you, madam, for giving us your positive feedbacks on this topic. So today's topic is like empiric use of oseltamivir in flu management. So today's our contents are sorry. So contents are healthcare challenges in monsoon and their diagnosis, influenza and its complications, clinical evidence of oseltamivir, and guidelines recommendation for empiric use of oseltamivir. So what are the key facts? Whenever we are just seeing the WHO site, so we can get this key fact that there are around billion cases of seasonal influenza annually, including 3 to 5 million cases of severe illness. It causes around 2,90,000 to 6,50,000 respiratory deaths annually, and 99% of deaths are in children under 5 years of age with influenza-related lower respiratory tract infections, and most of them are in developing countries. The symptoms begin 1 to 4 days after infection and usually last around a week. So healthcare-related challenges in monsoons are like influenza-like illnesses, H1N1, severe acute respiratory illness, and COVID-19. So dynamics of the occurrence of the influenza in relation to seasonal variation. This was a study done in Chennai, Tamil Nadu. It was a 7-year cumulative study, and which was done in King Institute of Preventive Medicine and Research, and almost 36,670 specimens were subjected to influenza analysis, and the overall duration was around 7 years. So influenza positivity started with onset of monsoon and peaks during the post-monsoon month. This was the inference from that study, and they have seen that what were the cases like in 2015, the overall influenza infection cases were 4,259. In 2018, it increased to 15,266, and 2019 it has increased to the 28,798. So this is 2015, 18, and 19. So as the years are going, the influenza cases are increasing day by day. So here we are seeing the deaths due to the influenza infections. So in 2015 it was 299. In this red box is showing 2018 deaths, that is 1128, and 2019 green is 1218. So incidence of influenza and related deaths are increasing alarmingly in India. So what are the symptoms of the flu? We see flu day in and out. Daily in OPD, maximum patients we see with the flu only. So what are the complaints? So fever, maybe with chills, body ache, headache, cough, sore throat, running nose, stuffy nose, tiredness, that means overall generalized weakness, and sometimes diarrhea and vomiting may be associated with flu. So it is a viral infection, so generally it may having multi-system affection. So let us discuss one case, which is a 2 years old female child admitted with the cough since 5 days, which was dry hacking cough, and cold since 4 days, which was running nose actually, and fever since last 3 days, which is high grade intermittent fever, responding to paracetamol. Her heart rate was on examination. Her heart rate was 125. Heart rate was 125. Respiratory rate was 35, and tachypnea was there. RS bilateral occasional clefts and bronchi. Provisional diagnosis, as we are seeing that this is a respiratory case. So we have provisional diagnosis was given as lower respiratory tract infection, and we have admitted this patient because of the high grade fever, not responding. Tachypnea was there. So for observation, we admitted this patient. Investigation was done. HB of 11, WBC count of 11,500, and polymorphs was 26, lymphocyte was 72, eosinophil count of 2, and monocyte count of 2. So platelet was 2,000, 46,000, CRP of 9. So here we can see that CBC is almost normal. Only lymphocytosis is there. CRP is borderly raised, nothing very high CRP. So X-ray was done. Again, X-ray showing there is a hilar prominence, hilar patch-like thing with hilar, some haziness here also. So we have labeled again this patient as LRT. We have started the patient on treatment. IV antibiotic was started because LRT, this patch was there. He was started with nebulization as the tachypnea was there, rhonchi and clefts were there. Patient responded to that nebulization and tachypnea reduced. But after on day 3 of admission, patient was looking drowsy, sick looking. Child was not accepting feeds, not very well looking child. So there was some problem that we saw that this patient whose tachypnea is reduced, ideally after starting antibiotic, this patient would have improved. But this patient is showing sensorium deterioration. So, and the age is around 2 years. So we thought of that this patient may be because of the H1N1 infection, because this drowsiness was the one of the clue for us, and we have sent the H1N1 swab. And after taking the swab, we immediately started the treatment on oseltamivir. Then swab came after 2 to 3 days, which was positive. So after starting oseltamivir, within next 48 hours, patient has shown improvement. Tachypnea reduced, fever reduced, his sensorium improved, child was playing, and then child was discharged. So this was the first case. So whenever we see the patients in OPD, so generally we are seeing viral versus bacterial. So it may be respiratory symptom like cough, coryza, and everything. So how do you differentiate between viral and bacterial? So in viral, generally it is acute onset, but it is more gradual than bacterial. Uh, Family history of similar illnesses, maybe there are some other family member maybe having some cough, coryza, or viral infection. In bacterial, generally it is to start with very high grade fever, and generally there is no other family member like viral illness. then patient is toxic in that bacterial infection. Cough has got predominant symptom in viral etiology. Bacterial generally cough is not there, so maybe absent. Cervical lymphadenopathy, if it is less likely to be in viral and it is more likely to be in bacterial. Associated symptom like rhinorrhea, exanthema, hoarseness of voice, diarrhea, conjunctivitis, all these symptoms may be more in viral because viral is a multi-system affection, and all these symptoms will be less in bacterial infection. If you do a local examination, there will be pharyngeal redness in viral infection, but there will be exudate, purulent patchy tonsils, or sometimes abscess can be seen in bacterial infections. So this was first case, and this was a differentiation between viral and bacterial. Let us have a let us discuss one another case, which is a elder child actually, who is a 14 years old boy, who was referred uh, from a means from a periphery to our center, and he has a complaints of low grade fever, sore throat, myalgia, sore throat for 7 days. Initially, there was no history of breathlessness, vomiting. There is no history of vomiting and diarrhea, and patient has received the ceftriaxone and piperacillin tazobactam before shifting to our hospital. So, but there was persistent fever. Child was also little drowsy. Mild tachypnea was there when we saw the patient. His pulse was 110, BP was 110 by 72. RS has shown bronchial breathing, which has suggestive of some respiratory involvement. Lung were involved. Maybe it was pneumonia. Bilateral coarse crackles and in the inframammillary area. So that area, subjected area, is maybe having consolidation. The X-ray showing mids and interstitial infiltrates. So as the patient was not improving after ceftriaxone, piperacillin, tazobactam, we have sent his nasopharyngeal swab for H1N1 also, and then which came positive later on. CRP was done, which was 10, not very high, sky high. CBS, baki rest other systems were normal. Laboratory evaluation revealed a normal hemogram, and liver function were normal. So everything was normal, but patient symptom and X-ray was not good. This is X-ray which is not a good X-ray. Actually, we can see a bilateral infiltrates on his X-ray. So this patient with this X-ray, H1N1, we are done after seeing this X-ray, which was positive. So what we have done, obviously, we have to start him treat him with oseltamivir. So along with the antibiotics, he was continued with the oseltamivir and paracetamol. We have given him good hydration. Hand wash was teach to the patient also and relatives also. And slowly the patient shows marked improvement in all his symptom, fever, tachypnea, and X-ray also shows improvement after few days. So this is the post-treatment X-ray, and the infiltrates on the X-ray was reduced slowly. So this is the second case. So I would like to ask Madam whether do you want put any inputs in these two cases, or what is your experience related to such cases actually? Madam, unmute Madam. Unmute.
My recent experience is nowadays viral flu-like illness is coming with the conjunctivitis involvement more. That is common nowadays. That much only I would like to add.
Yes, ma'am.
Thank
Okay.
you.
Yes, thank you, madam. So let us have some theory now, like influenza, about influenza. So it is a influenza virus is the one of the most common virus, and it is most common infectious disease caused by influenza virus. It is highly contagious airborne disease that occurs in seasonal epidemics and manifests as an acute febrile illness. So it can cause sometimes mild illness, it can cause severe illness also. So serious outcome of the flu infection can result in the hospitalization also, that we have already seen in our cases. Sometimes it can cause death also. So we should not take this patient as lightly. And this is a basically diagram of the influenza A virus actually. So why I'm showing this, because there is a basically depending on their surface proteins and their mutation, they are basically classified into like this is a H means H hemagglutinin and neuraminidase. These are the two proteins, surface proteins, which goes on. There is some mutation into that, and they goes on changing. So that it is labeled on that two surface proteins like H1N1, H2N3, H5NY. So there are various mutations which are occurring every 1 to 2 years. They are getting mutated, and so that's the reason that we have to change the vaccines every 1 or 2 yearly. So what are the nowadays which is going on? H1N1 and H3N2. These are the two influenza viruses which are common nowadays. So what are the overall types of influenza viruses? So it is type A, type B, type C. Type A causes mutations and frequent epidemics due to the minor antigenic variations and periodic pandemics. Pandemics, it's a large extent due to the major antigenic variation. Influenza B virus infects only humans and it causes local epidemics. And C virus is generally mild virus and it infects human and swine. So, but it is mild virus, so nothing to worry about it, mainly about influenza C. So main problem is influenza A virus only. So how do you see the flu virus transmitting? So basically it translates from the droplet which are transmitted, which are actually goes into air while we are talking, sneezing, or coughing. And if the another person is within 6 feet of distance, then that person may catch that virus. Again, the immunity is one of the factor that whether this person will get it or not, but within 6 feet of distance, that person is getting exposed to this virus. So, so whenever somebody is ill, like having flu-like symptom, influenza-like symptom, always he should be away from other people. He should not go to, if the children with flu should not go to the school. If the adult is affecting with flu, he should not go to the office because he will give that virus to other colleagues or other children also. So whenever there is a either patient or family member should do a proper hand washing with soap and water. That is very important because flu is also transmitted from fomites. It is not always airdrop transmission. It can transmit through fomites also. So most of the healthy adults may able to infect other people beginning 1 day before symptoms and 5 to 7 days after becoming sick. So 1 day before and 7 days after. This is the time when the one person can transmit the virus. In children, children may transmit the virus after 7 days also. So generally we see in monsoon season, we see like 4 type of illnesses. Like first is influenza-like illness, then H1N1 is seen, SARI, severe acute respiratory illness, and COVID-19. So most of the symptoms are like they are same looking, but there are minor differences that we should be knowing. So fever, myalgia, cough, lack of energy means you can say that weakness. We can say generalized weakness, sore throat. These are present in all the symptoms. Sore throat is also present in all the 4. Breathlessness, generally influenza-like illness, it will not have that much breathlessness. The rest other can have the breathlessness. Loss of smell and loss of taste, we have seen in COVID that is a characteristics of COVID. So if there is a loss of taste and loss of smell, then we should think of COVID-19. Nowadays, it is very rare nowadays again. But we should keep in mind, diarrhea generally can be seen in COVID-19. Sometimes we can see it flu also, H1N1 also. Headaches is generally may or may not seen in influenza. It is seen with H1N1, may or may not be with SARI, COVID-19 sometimes. So basically, it is not very clear. So headache may be there in all these conditions. So what are the emergency warning signs of flu sickness? So which patient we should be more alert? So in children, we are seeing that if there is a tachypnea, fast breathing, we should be more alert. We should admit those patients and we should keep them in observation. If there is a blue color, that means cyanosis is there, oxygen is hampered. Definitely, you should observe that patient. If the child is not able to take fluid, so he is not able to take fluid, he is not able to eat, then always that is very important. If the child is not waking up, then again means the child is sleeping more, not interacting. Again, it is a danger sign. If the child is irritable and if child does not want to be held, then again we should keep watch on that patient. Flu-like symptoms, first it improved and again deteriorated the patient. We should keep a watch. Fever with rash, we should keep a watch. And if the child is infant, like small baby, and then we should keep the following signs important, like keep in watch on the following sign. First is unable to eat or drink, tachypnea, difficult breathing. When the child is not having tears while crying, means the child is so dehydrated, there is no tear, and the urine output is reduced. So these are the things that we should be keeping in mind when we are treating or seeing these patients of influenza or flu. So what are the complications now? So it can have a lot of complications. First is pneumonia, second is bronchitis, third is ear infection. Then if the child already has got asthma or COPD generally in the adult, if the child has got allergy or asthma, it may deteriorate. ARDS can be some very few patients can go into ARDS, but this is a dreaded complications, and we should be very much aware about these complications. So whenever the child is becoming hypoxic, keep this complication in mind, and rarely or it should not happen, but death is also one of the complication of the flu. So who is at higher risk? Means everybody is at risk, but most of the normal patient will have flu for 5 to 7 days that we already seen. But those patients with some comorbidities, they will have more problems because of the flu. So who are they? Like first is like those who have got allergy asthma. Second is any chronic neurological liver kidney disease. They are thoda sa immunocompromised, and that's why they can have more flu symptoms, severe flu symptoms. Juvenile diabetes can have the severe flu symptom. Immunocompromised patient because of the HIV, cancer, immunosuppressive medications, they can have more problems. Sickle cell disease, obesity, and those who are living long-term care facilities, so they are more prone for the more complications. So now we are going to management. So always supportive management is very important. Bed rest, you have to give more fluid intake. If required and very irritating cough, then go for cough suppressant. As a routine, we do not use cough suppressant. Only if the child is very uncomfortable, very dry, irritating cough, then for short time you can give this cough suppressant. Analgesic, antipyretic as paracetamol. NSAID if required, but generally try to avoid other NSAIDs. If there is a myalgia, you can give 1 or 2 doses. So most of the patient with influenza recover in 3 days, but however, malaise can be persist for weeks. Severe cases may require IV hydrations and other supportive measures. So what is the specific treatment? This is a general treatment, supportive management. So when we are talking about specific antiviral treatment, there are two groups of the drugs. One is neuraminidase inhibitors and other is adamantane, that is M2 channel blockers. So these are the two groups of the antiviral that is used for antiviral treatment. So first one is like neuraminidase inhibitors is like they block the viral neuraminidase enzyme, which is critical in the releasing virions from the infected host cells. म्हणजे त्या host cells they means whatever the viral is coming, viral virions are coming. So this is blocking that virions. And these drugs are active against influenza A and B. The like examples are oseltamivir and zanamivir. And other group is like they interfere with hydrogen ion channel activity of the influenza virus, thus blocking its entry into host cells. So they will not allow the entry into host cells. And the examples are they are used only in influenza virus, amantadine and rimantadine. So basically, but we know that which drug we are using, which is available is oseltamivir. So let's learn more about oseltamivir. So, a potent and selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. So, basically, it inhibits the neuraminidase enzyme, which is a selective inhibitor. So, it is basically a oseltamivir is prodrug, which is converted into oseltamivir carboxylase in the liver, and that acts on the viruses. It inhibits influenza virus replication and its pathogenicity. It prevents further spread of infection. It is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1, and H9N2 strains. So how does it act actually? So these are the neuraminidase inhibitors which will act on the virions of this influenza virus, and it will not allow the virions to release, so it will halt the viral replication. So it was the first oral neuraminidase inhibitors. It was approved oseltamivir is approved in more than 100 countries. FDA, CDC, American Academy of Pediatrics has approved oseltamivir for the treatment of influenza virus. So let's learn about the drugs and The doses according to the age and weight. So in adult, the standard dose is 75 milligram capsule twice daily. Children, we have to go on weight. So if the child is less than, so first we are talking about treatment part, huh? And later we'll discuss about the chemoprophylaxis. So first thing is like if the weight is less than 15 kg, it is 60 milligram per day. It is divided into two doses. If it is 15 to 23 kg, 90 milligrams per day divided into two doses. 23 to 40, it is 120 milligram per day divided into two doses. And more than 40, it is adult dose, that is 75 milligram today. 75 milligram twice daily. So, if the child infant 2 weeks or to less than 1 year of age, then it is 3 milligram per kg twice daily. Chemoprophylaxis. So, when do you give chemoprophylaxis? So, here it is mentioned that it is recommended in community outbreaks, that is seasonal or pre-exposure prophylaxis, and the duration of the prophylaxis is around 6 weeks. And in immunocompromised, we can go to 12 weeks. So, what is the dose for this immunocompromised? Sorry, what is the dose for this chemoprophylaxis? So, adult it is 75 milligram OD. Basically, it is, you can say that we are giving 30 milligram BD. So, 30 milligram OD is the prophylaxis dose. So, prophylaxis dose is OD and that one-time dose. So, 30 milligram for less than 15 milligram, 45 milligram for 15 to 23 kg, 60 milligram for 23 to 40, and adult dose like 75 milligram for more than 40 kg. So, first important thing is that hetero has got a 30 milligram capsule available. So, those children also who are able to swallow those capsule, we can give them 30 milligram capsule also. So, we have our available syrup also and capsule of 30 milligram which can be used in children. Second important thing is that whenever you are starting treatment with oseltamivir, always start as early as possible and best within 48 hours. But second statement is that if by chance you are late, do not withhold the drug because it is late. Whenever you are thinking of that H1N1 or flu, you please start the year. But if it is, it will give the best result if it is start before 48 hours. So now we are discussing with the benefits of empiric early use of oseltamivir. So basically, oseltamivir treatment of the influenza illness will reduce lower respiratory tract complaints, antibiotic use, and hospitalization. So, there is a study which was done on 3,564 subjects, and it has shown that in patient with influenza, oseltamivir treatment reduced the antibiotic use by 26.7%, lower respiratory tract complaints with around 55%, and hospitalization by around 59%. So reducing the occurrence and severity pneumonia due to H1N1 by early oseltamivir administration. So there was study which was done, which has studied 442 patients, and the median time of giving oseltamivir was around 5 days. But the subjects were divided into 4 groups, like if it is started before 2 days, 3 to 7 days, 8 to 14 days, and after 14 days. So what was what they have seen, that both the probability of any severity of pneumonia and the probability of severe pneumonia increase gradually with the time from symptom onset to oseltamivir administration. So if you administer oseltamivir late, the chances of pneumonia will be more. Earlier initiation, there will be less chances. And even when administered 48 hours after symptom onset, it has showed the considerable potential to reducing pneumonia. So as we have discussed, start early, but if you are late, please start it so that it will give some benefit. Again, patient with shorter time of the means, if we are given the oseltamivir early, that is the shorter time. So those patients were discharged earlier from the hospital as compared to those who are started late. So it reduces the duration of the hospitalization also. So now there is another study which has studied that oseltamivir along with azithromycin, does it has got any benefit? So here is the graph that shows the oseltamivir and azithromycin combined treatment offered significant reduction in the incidence of secondary bacterial infection, and it required less respiratory support. So these are the This is the group with both drugs received, and this is the group who has received only oseltamivir. So this is the incidence of secondary bacterial infection and incidence of the respiratory support. So you can see this red group with azithromycin and oseltamivir, and blue group with only oseltamivir. The another findings was that oseltamivir azithromycin combo treatment offered significant reduction in hospital stay and the severity score has reduced. So basically combination is giving some benefit. So there is a guideline recommendation. So what are the WHO recommendations? Empiric treatment, if you are thinking of H1N1, empiric treatment is strongly recommended. Treatment should be started as early as possible. Laboratory confirmation is not necessary. If it is possible, if patient is affording, it is available, please do it. And you start the medication and immediately you send the reports if you are strongly suspecting. But if it is not possible, then we can do without that laboratory investigation also. Negative test does not exclude the H1N1. So sometimes there may be some faulty techniques or there may be some fallacies in taking the swab and everything. So negative report does not exclude the diagnosis of H1N1. So if you are strongly suspecting H1N1 and the report are negative, still you can continue the treatment. Then higher risk individual have been exposed to the patient with influenza. Consider presumptive treatment with oseltamivir. Again, early empiric supportive therapy and monitoring should be done. Give empirical antimicrobials to treat all likely pathogen causing SARI. Empirical antibiotic treatment should be based on your clinical diagnosis, your clinical judgment, whether it is community acquired pneumonia, whether it is healthcare associated pneumonia, whether it is in healthcare setting or sepsis or something. What are your antibiotics which are commonly used? What is your sensitivity in your area? All these things can decide your antibiotics. And empirical therapy including oseltamivir, like basically neuraminidase inhibitor means oseltamivir. Whenever there are risk factor or there is a travel history or there is the annual influenza exposure is you have seen or the very history of exposure, then you should give the prophylaxis with oseltamivir also. So what is the overall summary to give? That proper diagnosis can and early treatment can prevent the flu complications. Empiric use of oseltamivir reduces lower respiratory tract infections, hospitalization, and antibiotic use. WHO, American Thoracic Society, recommends empiric use of oseltamivir. So thank you very much. So, madam, do you want to add anything? Any specific
No,
things which
no,
I
no,
may have forgotten or something like?
What is
no.
your
You
experience,
covered
madam?
everything.
What
Very
is your,
nice.
what is your experience, madam, on oseltamivir?
There are no side effects. Patient accepts your preparation. Taste is palatable, and results are quick. Patient becomes asymptomatic within 24 hours.
For prophylaxis, it is best to start as soon as you can.
Yes.
Even in the family
Whenever
business or
it is in your mind,
mind,
then
Yes.
start.
better start as soon as you can because
Yes.
it works only for prophylaxis, not actually for treatment,
Mm.
especially in children. And secondly, what I wanted to know is if this viral flu continues, there's always a chance of superadded bacterial infection. But
Yes.
how common is a atypical bacterial infection in children?
A typical bacterial infection is common when any of the family members is affected.
Okay.
That time it is more common atypical, and then patient was previously non-toxic, and then patient becomes toxic.
Suddenly becomes toxic. And in this influenza virus, the spread is largely, I suppose, preventable if people start wearing masks.
Yes.
Because that's what has been happening even in Mumbai, because people generally have got habit of using mask after the COVID incidences. But then also, I suppose the microscopic all masks may not prevent that
That
virus
is there.
spread. Yes.
But still it becomes barrier. Mask becomes barrier
Yes,
for
a
most.
physical barrier. At least there'll be some prevention.
Mm.
And the same measures that we did for COVID, like gargle and hot water and fermentation, same thing would work for these viruses also. H1N1.
Yes.
सर तुमचं हे म्यूट वर आहे
Yeah. Supportive management is also
Is
always
also
important.
equal.
Yes.
And
Yeah.
I mean, people have got this habit of asking vitamin C, zinc supplementation. It is said that they boost immunity. Would they reduce the incidence of viral infections?
No.
No.
So, but
Not
it
really.
will see generally to boost immunity, we can give vitamin D and
Ah,
everything. So
ah.
it is everywhere. In allergy also we give
Exactly,
vitamin D.
exactly.
In any viral infection we can
Exactly.
do with
There is
zinc.
no
That is
harm in
not.
giving
Yeah.
like there is no
Yeah.
harm.
So we can give additionally, but it is not key. There is no curative effect or
Ah.
something. It is always supportive.
It will not do anything for
It will,
virus.
it will help in improving immunity and all those things. So definitely
Maybe
we can do it. No
maybe
problem.
that the severity of attack may be reduced.
Vitamin D is now everywhere, so we
Vitamin D.
can give in
Now,
all
I
the
was
conditions.
specifically about vitamin C and zinc because these things, lay press lot of things are
It
said
will
about
also help because zinc will help in the mucosa this replenishing. So
replenishing.
whatever damage is there, so definitely zinc will also help. But
Yes.
in convalescence phase, it will help more than the
Okay.
active phase.
The active phase.
So we can give no problem. Supportive management is definitely recommended.
Right.
Yeah.
Thank you very much. Thank you,
Yes,
Dr.
thank you.
Pawar. Thank you, madam. Thank you.
Thank you. Thank you.
And
Thank you, madam. Thank you, madam. Thank you,
once
sir.
again, I take opportunity to thank all the participating doctors who took time from their schedule and attended. Thank you, marketing team Hitro, for conceptualizing this. Thank you, field people of Hitro, for making it possible. Last but not the least, thank you, IT. Thanks, Giridhar, for this wonderful IT support. Thank you, all of
Thank
you.
you.
Signing off and wish you a very pleasant evening. Thank you.
Thank you. Thank you.
Thank you. Thank you, madam. Yes, thank you.
Thanks, Giridhar. Thanks, Samriddhi.
Thank you, doctor.